Okay, let's start. Okay, good evening, guys, again. Welcome back. We are a little early today because we have another lecture, another module, another course going on, actually. That's the reason. I hope you are all comfortable with the time. So, from next Thursday, we will continue with whatever uh, we were, practicing. So, at 7 to 8:30 will be time from the next Thursday. Everything will be there in a group, so don't worry. So, we are discussing clinical syndromic stewardship, the second module, right? Second module and the lecture number 8. So, today we are going to discuss about, in the last Thursday, we discussed about some very basic thing related to sepsis and all, right? Today we are deep diving into the urinary tract infection, and we will see some of the very complex scenarios associated with UTI, where exactly, stewardship makes a big impact. So how to handle, in which situation there is no need to treat, that we need to identify, because many UTI patients are undergoing into the treatments, and 90% of these patients didn't have to take some medicines and still they are taking. So we need to identify those super complex cases, in which scenarios not to treat, in which scenarios we need to treat with the antibiotics, that we need to clearly identify what is, a complicated UTI, uncomplicated UTI. We know, as per our theory and whatever our textbook is suggesting, based on the signs and symptoms and the laboratory things. But apart from that, also we have multiple things in UTI. So today's topic will be clinical syndromic stewardship associated with the urinary tract infection. I'm sharing the screen with you all. Just a minute. So I hope the screen is visible to you guys. May I know? Okay, thank you so much. Just a minute. If you found any glitches in between, if I'm not audible enough or if the slides are not visible in between, please feel free to drop the message in the WhatsApp, as well as in this, Zoom, the Google Meet. In that chat box also you can put the message, so that I can get the notification and we can resolve the issue. Okay, so don't forget that. Just a minute. I hope it is visible. So, this is the title, guys. We are discussing today UTI complex clinical scenarios. And we are, before we start, I want to clarify one super important thing very, very clearly. So, this lecture is not about learning with antibiotics, that treats UTI. No, we are not going to discuss about therapeutics. See, when I say UTI, what comes into your mind? UTI can be studied in different ways, right? We can focus in 1 hour on only the pathophysiological events. It has either we can do that, or we can only focus on the therapeutic approach that is there for to treatment, right, as it to treat the UTI. And we can also just focus on the general things about the UTI as well. But that is what I want to make you very clearly, to be understand that this lecture is not about learning which antibiotics treats UTI. Okay, our focus is little different. We are discussing stewardship angle, so our focus is little different. This lecture is about clinical judgment. Okay, clinical judgment. So it is about deciding whether the patient even has a UTI or no. That is the main primary thing. As I earlier told you, I will show you some ratio as well, that some real articles are, published, that how many patients are mistreated, right? They are not actually have they are not having the actual disease, still they are getting the treatment just because to avoid certain conditions in the future. And that is a stewardship angle to observe, right? And that is what the clinical syndromic stewardship is all about. So this is deciding whether the patient even has a urinary tract infection or no. So in antimicrobial stewardship, this UTI are one of the largest areas, largest areas you can consider for misuse, guys. That's the reason I have put one of the topic to discuss about clinical syndromic stewardship in advanced AMS. Okay, so please understand it is the largest area of misuse of antibiotics, not because I can say not because doctors don't know, right, the antibiotics, but because of diagnosis itself is often wrong. You need to identify the gap in between. Okay, so today we will focus on recurrent UTI. We will see this is professional managing. We will see how to professionally manage recurrent UTI. We will see some of the catheter associated UTI, that is CAUTI, that is catheter associated UTIs. We will see asymptomatic bacteria, that is one of the situations to understand further when it comes to UTI. And also we will see the most dangerous scenarios, which can be an elderly patient with confusion stage and a positive urine culture showing a UTI presence. So I will discuss some complex patient population scenarios to you. So by the end of this session, you should be confident enough, to stop an antibiotic, not just to start. I know that you are already aware of the algorithm your DPRO is suggesting, and our reference books are having how to manage UTI, how to differentiate between this complicated UTI and uncomplicated UTI, how to identify the actual risk factors and all, root cause analysis we need to do, and accordingly we need to do the treatment and all. But that these things are already written, right? What is not written is you need to understand when to stop an antibiotic, right? When not to further treat the patient with antibiotics. That is what the stewardship perspective. We are here to stop the irrational use of antibiotics. We have the very clear aim of right drug at a right time, with the right dose at a right frequency to the right patient, of course at a right cost. And we need to decrease the overall prescription burden, right? We are here to increase the patient compliance and the adherence, right? And all of this can be possible with minimal effective treatment. So that's our primary goal for the session today. I hope now you have built some of the understanding that what this lecture is holding. It is not about pathophysiology and not about therapeutics, but it is all about clinical judgment, right? And it is all about the clinical pharmacist or a healthcare professionals. Those can actually works towards the stewardship decisions when to stop an antibiotic. Now that is skill, guys. Okay, not a single algorithm can tell you that yes, if this is no, this is yes, you should stop. No, this is not like that. Every scenario will be different, every physiology will be different. Okay, every UTI reason will be different. So we need to think in a very critical way, and that's where skills are required. Okay, theory is secondary, skills are the primary in this type of scenarios to handle. So let's start with the very first question, why. So I always start the session with why, so that it makes you more curious about learning why we are learning this topic. Because as I was a student, I was always wondering, 90% of the time I was wondering why this topic. So that why should be very clear to us before we are jumping towards the whole module. So why UTI are a stewardship priority? Why I have kept this particular lecture in the second module, where we are going to discuss about this clinical syndromic stewardship, right? I can either write some another disease as well, but why UTI? So these are the reasons, guys. UTI are among the top three indications for antibiotic prescriptions worldwide. That is one of the important reason to study UTI. We cannot, neglect. Okay, so UTI is a very simple situation when it is not complicated much. It can cured as well. Okay, it can preventable as well, but still it is one of the top three indications for antibiotic prescription worldwide. Top three, and I'm saying worldwide. Okay, one of the most common reasons for the antibiotic use. So in the OPDs, emergency departments and hospitals, this UTI is one of the most important cases. High rates of over treatment. Okay, so now here is the problem, guys. A very large proportion of these prescriptions, high, prescriptions are very heavy. These are unnecessary in like half of the population, if you are observing a UTI cases, half of the population is receiving unnecessary medicine for this. Why? Just because urine culture are sent without any symptoms, just because I can say positive reports are, they are treating reflectively, or colonization is mistaken as an infection. I hope now you have idea about what is contaminants and what is the real infection. Okay, so some colonization is mistaken as an infection and they are treating with the antibiotics. So what this all things can lead to? So this leads to three or four major consequences, I can tell you, right? Very first is the resistance, right? AMR, major driver for AMR. And that's the reason I have kept UTI in a clinical syndromic stewardship to understand. Because, yes, stewardship is what? Antimicrobial stewardship is working to decrease, to our primary goal is to reduce this resistance burden. And whatever is driving this resistance, we will work on it. So, AMR, antimicrobial resistance, of course, resistance will be there by the E. coli or this extended spectrum beta lactamase ESBL producers, carbapenem resistance will be there. Second, C. difficile. Now that is Clostridioides difficile infection. These are very common in the elderly patients, guys, right? And some recurrent UTI also happen that becomes more harder, more harder to harder, I can say, to treat further if it is recurrent, right? Every time the pattern will be unique to treat, and your previous medicine, whatever you have used, that will be resistant, that will develop resistance. So these are the scenarios happening with the UTI situation. So this UTI are, not a small issue anymore. They are, I can say, a core antimicrobial stewardship battlefield where you as an AMS expert can, do a lot of things, immense role you can play to eliminate unnecessary antibiotic use and to identify whether the patient needs actually the treatment or no. Correct. But for that reason, I have included in a clinical syndromic stewardship a urinary tract infection to study. I hope now why is clear to you, that why we are studying. Okay. You can now understand that it is one of the most common reason for the antibiotic use. We have high rates of over treatment in it. It is top three worldwide. Okay, top three. I can consider top three indicators. We can consider for antibiotic prescription worldwide. That is enough reason to study the stewardship in the UTI things, correct? So let's start with the UTI spectrum. Okay, so you need to understand this slide is extremely important conceptually, I can say. If you want to clear your concept, this slide is very, very important. Okay, let's understand one by one. So you know what, when the bacteria are found in the urine, whenever the bacteria is found in the urine, it can mean the very a very large extension it has. Okay, the meaning of extensive meaning it has, I can say. So three things can be possible here. Three things can be possible here. Whenever a bacteria is found in a urine, it can mean three very different things which are listed on the left side. So first is, it can be true UTI. Okay, it can be true urinary tract infection. So here bacteria are causing inflammation and bacteria is the reason behind the symptoms patient is having. What can be the second possibility? Second possibility can be asymptomatic bacteriuria. Now this is another situation, guys. It is abbreviated as ASB, asymptomatic bacteriuria. So in this, what happens here, bacteria are present, but it is not the reason behind the disease. Okay, it is not the actual cause for the disease. How can you identify? That is our topic of the discussion. So in upcoming slides you will get it. So very first possibility can be, of course, it is directly UTI. Okay, second possibility can be asymptomatic bacteriuria. So that is abbreviated as ASB. Please remember, here the bacteria are present, that's the reason you are seeing the positive this urine culture, right? But the bacteria is not the actual reason behind causing the disease. And the third possibility, that can be contaminated sample. Contaminated sample. Now, this is especially very common in the poorly collected urine samples. When we were discussing about our first module, microbiology, I have told you, right? Pre-analytical, analytical, and post-analytical errors can be happen while handling samples. So whenever the sample is being taken, that is also possibility of error while handling this. before your sample is reaching to the laboratory, there is chance of contamination. In the laboratory, while handling also, there is chance of contamination, and afterwards also there is a chance of contamination. Every step there is a possibility of error, right? So that is what the contaminated sample is all about. So clinically, I can say this three look, the same in a lab report. Every three parameter, this three possibility will be looking same in the report, right? Lab report is showing you a positive bacterial growth. Okay, but only one of them needs antibiotic, guys, and that is the very first true infection. But you need to identify whether it is true or whether it is colonization. Okay, so I hope you have idea now, because we discussed about microbiology in microbiology module. What is colonization, right? So those are not true bacteria, but those are contaminants, right? So this is what you need to understand, and only one possibility is there about true infection, and only those needs antibiotics. But unfortunately, I can say 90% of the time, 90% of the time, while handling UTI cases, if the if the urine report comes on a second day, if it is positive, apart from looking to the second and third thing, directly antibiotic is being prescribed to the patient, and this is happening in a 90% of the cases. That's where stewardship comes in. Okay, so remember, only one of the situation, needs actual antibiotics, and stewardship is about learning how to separate these conditions. Okay, so we are not learning pathophysiology or therapeutics or pharmacology, guys. We are here learning a clinical judgment, which is out of our, reference books and out of our textbooks and whatever we are doing. No one is making us understand how to separate this situation, right? That's where exactly stewardship is standing, and that is who is responsible for that. Of course, the healthcare professionals like us is responsible to separate these conditions and to know in which scenario exactly the medicine is needing. Okay, there is a need of antibiotics. So that is what we need to understand. This is called UTI spectrum. Okay, so let's understand what defines a true UTI. How we can understand that it is a true UTI, because true UTI is there, then and then only the antibiotics will be beneficial, right? Beneficial. So to diagnose the true urinary tract infection, there is three pillars. Okay, so there are pillars that three pillars are there that must be present together, and then you can consider that this patient is having true UTI. If you have note and pen with you, please note it down, these things, because these are very important things to remember later. So of course we need to understand, if I am observing a UTI patient, okay, I cannot say urinary tract infection patient before I can just confirm that yes, it is a true infection. So whenever I have seeing these signs and symptoms which are associated with probability of having UTI, possibility of having UTI, so what I will check, I will check three pillars, guys. Very first, I will check symptoms, of course. Okay. So diagnosis requires the presence of symptoms. Without symptoms, infection cannot exist, does not exist. So very first thing is symptoms. Second is this condition called this pyuria, right? This pyuria means white blood cells present in the urine. White blood cells present in the urine, that is indicating directly the inflammation condition. Okay, if it is not present, it is not the true UTI case, whether the patient has symptoms or no. Okay, so you need to understand first the symptoms. Second, if the symptoms are all indicated UTI, you can second have your focus on this pyuria condition. That means white blood cells are present in the urine, that is actually indicating the inflammation. And third, you need to understand is a positive urine culture report. Okay, positive culture, that is showing you a uropathogen. Okay, the actual reason behind causing this disease. So even if one of this is, one of this is missing, like three pillars we have been discussed, right? Symptoms, pyuria, and positive culture. If one of this is missing, the diagnosis becomes questionable. Okay, but what happens, as per my experience, I can say only on the basis of symptoms they are diagnosing the whole UTI case, and patient are already having the antibiotics and all. So you need to understand that diagnosis will be questionable if one of these is missing in the case. Okay, so the absence of any of this element that requires a clinical reassessment, that is what the ideal situation is suggesting you. For an example, if the positive culture report is there, but no symptom is there. Okay, blood report is showing the sorry, culture report is showing you the presence of the bacteria, but symptoms are not appearing, so that is not a UTI case. If symptom is there and no pyuria is there, again we need to think of other diagnosis that can be possible. Okay, we have another conditions. Then if only the pyuria is present, no symptoms, no positive culture, still it is only the situation related to inflammation and not infection. Okay, so we need to understand the symptoms, this pyuria and positive culture altogether, these three pillars that can you can fit into your mind while handling UTI cases. So this slide alone, I can say this slide can alone prevent hundreds of unnecessary antibiotic prescriptions, but people are not aware of it, right? So these are the very important things. Now we were discussing about very first pillar, that is symptoms. So let's discuss about this core UTI symptoms, guys. Let's be very clear about what symptoms we actually count in the UTI. So the true lower urinary tract symptoms, lower urinary tract symptoms, that includes the right side, you can focus, that includes this dysuria, urgency, and frequency symptoms. What do you mean by it? Dysuria means pain or burning while passing the urine. Okay, pain is happening or burning sensation is happening while passing the urine. Urgency is sudden need to urinate. Okay, sudden need or sudden urge to urinate frequently, and frequency is passing urine very frequently. So this type of symptoms are the core symptoms for the lower UTI. Okay, for upper UTI, for the upper urinary tract infections, that symptoms includes the fever and chills. Okay, chills is not written here, but that is also very common. So fever and chills are common. Apart from that, flank pain is also very common. Okay, so suprapubic or flank pain, that is above the abdominal, little sorry, your below your stomach line, that is area that is causing pain. Okay, so those are the very important symptoms that you can consider as a core symptoms. So I want to stress something very strongly, that there is no sign of confusion, there is no cloudy urine, and there is no foul, I can consider that there is no foul smelling of the urine, bad smell of the urine is there. So these are not the diagnostic symptoms of UTI, guys. Okay, if there is a cloudy urine or bad smell of urine, so it is not considered as a symptoms of UTI. Please understand, sometimes misinterpretation happens based on that. So this is where most diagnostic errors occurs, especially in the elderly patient. So bad smell of urine and cloudy urine, and if the patient has something like confusion stage and all in the elderly patients, this is very common. So these are not the sign of the UTI. UTI has a very core sign like fever, flank pain, and these three are very important: dysuria, urgency, and frequency. So this you need to understand, right? So these are some of the core UTI symptoms. Let's understand now what is recurrent UTI. Okay, so this is very popular terminology when we are understanding the UTI. So recurrent UTI is not a it is not a broad term. It has a strict definition, guys. Recurrent UTI is not a broad term. Okay, it has a very strict and concise definition. Recurrent UTI means two or more UTI in a 6 months. Very clear. So recurrent infection is defined as greater than or equal to 2 UTI in a 6 months. So you will be having a two episodes of this UTI in less than 6 months or in a 6 months, right? So that is what the recurrent UTI means. It has a very strict definition. You cannot tell when you will be asked further, to explain recurrent UTI, that yes, it is occurring. It is recurrent. No, it is not like that. It is not a broad term. It cannot be misinterpreted as well. Recurrent means there is two or more UTI in a 6 months. Okay. Or in another line, you can say three or more UTI in a 1 year, 12 months. So greater than or equal to 3 episodes of urinary tract infection in 1 year. That is the situation of reoccurrence. Okay, so we must differentiate between the two very different, concept. And here it is written requiring a careful distinction between relapse and this reinfection. Okay, this is a thin line. There is a thin line difference between what you call a relapse and what you called a reinfection, guys. Okay, it sound alike, okay, and look alike also, we can say. It looks same, it sounds also very same meaning it is holding, but it is having a thin line difference between these two terminologies. Relapse, let's understand relapse. You know what, same organism comes back. If it is e coli will comes back in a second episode or third episode in a year. So same organism comes back, usually due to inadequate treatment or persistent focus, I can say. So inadequate treatment, inadequate dose, that can be reason behind the same organism will be found further in a the next episode. That is what you can call the relapse, right? And reinfection is a completely new organism that can causes a new episode of UTI, guys. So in that you will find a new, like it is not E. coli, it is something else. So this is the differentiation between relapse and reinfection. This is one of the most common question recruiters, or if you are in an internship, they it is most common questions that is being discussed throughout your clinical practice or in a ward round, right? This is very important. Relapse and reinfection. Relapse means same organism comes back, usually due to some inadequate treatment, and reinfection is completely new organism is causing the new episode of the UTI. So why this differentiation matters, guys? Again, because why is very important. Why this distinction important? Because relapse suggests you treatment failure in a stewardship perspective. What do you mean by treatment failure? Because see, same organism is coming back, right, in a second episode. Just imagine your previous treatment won't be effective, right? That was not effective enough to kill the whole bacterial growth present in the urine. That's the reason behind the same organism is evolving further. So relapse means that is suggesting you the treatment failure, while reinfection suggests you the risk factor the patient is having, the host is having, and the colonization as well. Okay, so please understand the perspective. If it is a relapse case, understand your treatment is failing. And if it is a reinfection case, think about the risk factors the patient is having. So I hope it is making sense to you. So next topic, of course, we will discuss risk factors of recurrent UTI so that we can understand if it is a reinfection, what risk factors we need to take care of. Because if it is a relapse condition, of course, we need to work on a treatment, on a treatment perspective. And we need to monitor that the patient is taking a full dose with the adequate, whatever, patient is stick to the guideline, adherence is there, compliance is there and all. But if it is a reinfection, we should focus on the this risk factors. So of course, the next slide will be risk factors for the recurrent UTI. But I want to ask you that whether it is clear to you or no. Because may I know that is it clear? Because it is very important, guys, to understand the recurrent UTI definition and what is the exact difference between relapse and reinfection. So all your thumbs ups are coming. So I hope you are getting the point. I am happy. If you have doubt, we can solve it later. Don't worry. So let's understand now, if it is reinfection, I should focus on what? The risk factors. So let's understand further what are the risk factors of recurrent UTI, guys. So recurrent UTI, usually don't happen randomly. There is always a link. Recurrent UTI, recurrent, of course, it is means a second episode or a third episode in a year, or a second episode in a 6 months, right? It is reappearing, it is reoccurring. So of course it has a pattern. It is not a random thing, right? And common risk factors includes, the very first thing is a female anatomy. Okay, females are more prone to develop this recurrent UTI. The reason behind it is very simple, because they have shorter urethra. Okay, so female has shorter urethra. That's the reason behind it is happening. The bacterial growth is more prone to develop in this area. So female anatomy is the it is a important risk factor you cannot ignore. And you have seen also, females are more prone to develop UTI as compared to male when we are discussing the epidemiological things. So this, because of they have the shorter urethra, females are having the anatomy like that to have this infection very frequently. Next risk factor is the diabetes, guys. Diabetes, we cannot ignore diabetes mellitus. So what happens with diabetes is, in a very simple line, see, there is a big physiology behind it, pathophysiology behind it, diabetes and UTI. But in simple language, I can say you that glucose rich urine, glucose rich urine favors the bacterial growth, right? So that is very important to understand. Diabetes has direct relation with the UTI. And in single line, I can justify. Again, I can say that there are multiple reasons very clearly explained in some reference books that what is the exact pathophysiology behind diabetes developing UTI, right? But the very single line I can say, glucose rich urine that favors the bacterial growth, and this menopause. So post-menopausal things, how it is associated. So as per my knowledge, I can say postmenopausal has estrogen deficiency in a woman, and that leads to loss of some protective vaginal flora, right? And if you don't have the protective flora in that area, then you will be developing, you are more prone to developing certain infections associated with this area, right? So genital area. So those are the reason behind the postmenopausal UTI infection, because this age, that lacks the estrogen. So estrogen deficiency leads to loss of some protective this vaginal flora. That is the reason behind it. Again, there are certain other reasons as well, but the most common is this. So just a minute. Yes. So these are the very first line. The female anatomy, diabetes, and menopause. These are the reason behind the recurrent UTI. The risk factors you cannot ignore if it is a reinfection. So if the risk factor is there, this in the reinfection, which is responsible to grow exact different, different organisms which are appearing in the reoccurrence. So you need to work on this particular risk factors, right? So of course you need to work on the diabetic profile and the estrogen things, and the female anatomy, how we can cure this particular situation if it is reoccurring. So that you need to focus. Okay, so these are the primary things you need to take care of. And apart from that, incomplete bladder emptying, guys, this is very important risk factor we cannot ignore. Incomplete emptying of the bladder. So what happens, residual urine, that act as a culture medium for the bacteria to grow. So incomplete emptying of the bladder is one of the issue, and that is one of the, I can consider a lifestyle related thing, right? So because of some disease also, patients are unable to empty the bladder completely, and because of their habit also, we can consider. But this is one of the factors, risk factors. So what happened in this situation, some residual of the urine that presents over the long period of time, and it act as a culture media to grow the bacteria inside it. So these are very important, and one of the biggest risk factor, it is in the middle, you can see. One of the biggest risk factor is actually prior antibiotic exposure. Prior antibiotic exposure, antibiotics alter your normal flora, guys, and that is selected for the resistant organisms, so that is creating a cycle of reoccurrence. Okay, so antibiotic alter your normal flora and select further the resistant organisms, further creating a whole loop or a cycle to reoccurrence. Okay, so relapse will be there in conditions of prior antibiotic exposure if the patient is having on a huge level. So these are one of the risk factors you need to understand while handling UTI cases. You need to understand what is the relapse case, what is the reinfection case, because in stewardship angle, primary thing is to observe this root things. Okay, the things which are fall under the roots, and that's where you can build your clinical judgment. Say this microbiology, we need to understand in the recurrent UTI how exactly it's being, it is look like. So in first episode of uncomplicated UTI, guys, what happens, First episode it is, and uncomplicated UTI it is. This E. coli is usually very sensitive. Okay, so E. coli is very sensitive, but in the recurrent, this recurrent UTI, when it is a relapse or a reinfection cases, your microbiology changes dramatically. Okay, so please understand, if it is a first episode and if it is an uncomplicated version, your E. coli will be there, and that is sensitive also. You can just, normal dose will be effective against this situation. But if it is this recurrent UTI scenario, relapse and reinfection is there, your microbiology will change dramatically. We will start seeing some ESBL producing E. coli version. What do you mean by ESBL? So ESBL means extended spectrum beta lactamase. So extended spectrum, it has itself the meaning. Their spectrum is being extended further, and they are producing beta lactamase enzyme. And this is the enzyme which is responsible to make them, resistant toward all of your beta lactam antibiotics. Okay, so that's where their name came from. ESBL, extended spectrum beta lactamase. Mase, that means it is an enzyme which is produced by the bacteria itself, which makes them resistant toward all type of beta lactam antibiotics. And that is one of the toughest thing to, cure, E. coli. Right. So in recurrent UTI, you will see this ESBL producing E. coli. You will see some of the Klebsiella species as well. Okay, Klebsiella species you will see, some Enterococcus species you will see. Okay, and this happens because repeated antibiotics are being selected for the cure, and it is a reoccurrent, right? It is recurrent UTI, so all of them will be resistant. Some bacteria will be there which are now present in the body, which can deal with your antibiotic, every antibiotic. Okay, that's the reason it is reoccurrent, right? It is the reason behind its recurrent UTI case. So this happens because of repeated antibiotics select the resistant strains further. So repeated empiric therapy, guys, whatever broad spectrum we are using to treat this kind of situation without any culture test, that is creating resistance in the patient's body. Just imagine having random antibiotics daily, and one day you will be having one situation, and any of the antibiotics won't give you any effect because you are taking it since long, and now the bacteria which were growing, that has mechanism to, to resistant to develop resistance further because they are familiar with your antibiotics. That is how the cycle is happening with UTI. Okay, so repeated empiric broad spectrum therapy without your culture reports, that is creating resistance, and we are here to solve this. This is the primary purpose of stewardship. Okay, so please understand, with an alarming trend towards MDR strains, that is meaning the same multi-drug resistance strains will be developed. Okay, so this is how the recurrent UTI is making a loop. And what is a stewardship approach in a recurrent UTI? Now we have idea what is relapse, what is reinfection, what are the risk factors to have a look, how to identify whether it is a true UTI or no. Now, how exactly the stewardship approach? So this slide represents your ideal antimicrobial stewardship practice. Okay, ideal antimicrobial stewardship practice. First step. First step is to avoid repeated empiric therapy to prevent resistance and ineffective treatment. Every reoccurrence, guys, that should not automatically get fluoroquinolones or cephalosporins. Okay, you might be having idea that, right? If in your family also, if someone has UTI, we are having this practice in our mind to let them, take the cephalosporins and fluoroquinolones because we are having idea that this is the ideal treatment of UTI. Okay, but please understand, we cannot do these things. First thing we need in a stewardship approach, that is avoiding this repeated empiric therapy. It can solve a temporary issue for you, but it will reoccur after 6 months, with the second episode or third episode in a year. And it is a reoccurrence, and the reinfection will be there, and at that time your cephalosporin and fluoroquinolones won't give you any effect. So, first thing is avoiding repeated empiric therapy. Okay. Second thing for our stewardship perspective is using the culture directed therapy. Treat what is grown, I will say. Okay. Treat whatever is grown, whatever identified in your culture reports, not what you have assumed. What happens in the OPD UTI cases, guys? 90% of the people coming in the OPD, they are not advised with the culture reports, and always, they are prescribed with the cephalosporins and the fluoroquinolones and some broad spectrum antibiotics. In 7 days, in 14 days, they will feel better and everything will be solved. But it is not the thing. The complicated UTI, that is recurrent UTI, right? That can happen in the future with the resistance. And this is how exactly we have now at a border of resistance, right? We are now, the resistance is becoming now a global threat to us. And this is the practice we were following. Of course, we need to change it, right? So, culture directed therapy, treat what is grown, not what you can assume. We cannot see the bacteria, of course, right? So, diagnostic guidance. Utilize culture directed treatment to treat the specific identified pathogens. And third is optimize your duration, guys. Longer treatment, that does not directly mean a better treatment. It only means more resistance and more adverse effect, I can say. Okay. So it is not like 7 day course. It is, let me take for 14 days, I will be better. No. Longer treatment does not mean better treatment. It only means more resistance and more side effect, adverse effects. So this approach, therapy optimization, this approach protects both the patients and our future antibiotic efficacy as well. So these are our stewardship approach, guys. This is how we can work. Okay, initial assessment, that you can just understand that avoiding repeated empiric therapy. Diagnostic guidance, we need to check the culture report, and we will treat whatever we are seeing in the report. And then the therapy optimization, we will work on the duration as well to just avoid future resistance pattern in the UTI. Now I have the another thing for you, that is catheter associated urinary tract infection. Recurrent ke baad, okay, it is very important to understand this CAUTI, that is catheter associated urinary tract infection. Now this condition behaves very differently from the normal UTI, guys. So this condition behaves very differently, and that's the reason I have kept in the module. Why it is so important? Why, I will justify you, don't worry. Just because you can see here the 1, 2, and 3 point. Because catheter forms biofilms. Okay, catheters are the reason behind forming the biofilms. That is a complex bacterial communities. Okay, biofilms, that complex bacterial communities attached to the surface. And within what happened, within 48 to 72 hours, 48 to 72 hours of catheter insertion, what you will see is most of the patient develops this bacteriuria. Okay, most of the patient. And this is expected also. Okay, this is not an unexpected situation. So whenever the patient has catheter insertion, after 48 to 72 hours later, like 2 days, 3 days later, most of the patient develops this bacteriuria, and this is expected. It does not mean infection. Okay, so please understand, biofilm formation on the surfaces are very common with the catheter. Rapid colonization of the device happens, and most patients are having a bacteriuric. That means most of the patients develop bacteriuria. And therefore, it is the reason a positive urine culture in the catheterized patient is completely normal. Okay, so if you are getting a positive urine culture report of showing a bacterial growth, but if the patient is catheterized, it is completely normal, not an abnormal thing. Only symptoms make it an infection if the patient will develop. Okay, so you need to understand what is this CAUTI. That means catheter associated urinary tract infection, and why it is so different. Because it is not an actual infection until and unless the patient is having symptoms associated with it. And now you know the symptoms, you now know what three pillars you need to identify. If the culture is positive, symptoms are present, and if your this pyuria condition is present, then you can say it is a UTI case and needs an antibiotic intervention further. Otherwise, no. Okay, so you need to understand this condition. Now, What is the difference between catheter associated urinary tract infection and catheter associated asymptomatic bacteria? Now this is interesting, right? Because I have told you there is three possibility. If your urine culture suggests you the positive bacterial growth, there is three possibility. In very first slide I have told you that it either can be true infection, either it can be ASB, that is asymptomatic bacteriuria, or either it can be simple colonization, okay, and not a infection. So of course these are the possibilities. So how we can differentiate between whether it is catheter associated urinary tract infection, because see, catheter associated has a name, that is UTI, while ASB doesn't have name of UTI, it is asymptomatic bacteriuria. There is a difference, okay. So this slide is one of the most important I can consider in a stewardship perspective, and this is also very important as per your examination, vivas, interviews and all, because these two names sounds very similar, okay, very similar. So what is the purpose of using two different names, this catheter associated urinary tract infection and ASB? I hope now you are familiar with the meaning, right? So, see, this catheter associated UTI, that is very simple, and ASB means asymptomatic bacteriuria. What happens in catheterized patients? Bacteria in urine. These are, almost universal, I can say. Okay, catheterized patient. What happens in the scenario in the catheterized patients? Bacteria which are present in the urine, that are almost in a sense of universal, okay. So the presence of bacteria does not define the actual infection in this catheter associated UTI, okay. And the only factor that defines this CAUTI, that is catheter associated urinary tract infection, is the symptoms, okay. So presence of bacteria does not define infection in CAUTI, okay. Only the factor which is defining this catheter associated UTI is the symptoms, okay. So whether the patient has catheterized, if the patient is having catheter and insertion, and if they are developing certain symptoms, then you can say that it is having a CAUTI, okay. Otherwise it will be the case of ASB. I hope now you are getting the point how we can link it, okay. So catheter associated UTI, presence of bacteria in the lab report, if you are seeing, that does not define an infection. The only factor that defines CAUTI is the symptom. If the patient has a catheter, a positive urine culture, but no symptom is there, then there is a catheter associated asymptomatic bacteriuria. Catheter associated CA will be there, and then another term UTI won't be there. Asymptomatic bacteria ASB will be there, and antibiotic should not be started in the condition of CAASB. I hope now it is making sense to you. Okay. If the catheter is there, if the positive urine culture is there, and the symptoms are also present, dysuria, pyuria, frequency, urgency, fever, flank pain, these are the symptoms also present. Patient is having a positive culture report and the catheter is inserted, then you can consider the situation is catheter associated urinary tract infection. Okay. So if this catheter if it is not, the symptoms are not present and the culture report is suggesting you the positive growth, this condition is known as catheter associated asymptomatic bacteriuria. There is no symptom, so asymptomatic, and antibiotic should not be started in this particular scenario. This differentiation alone can reduce a huge amount of unnecessary antibiotic use in the hospitals, I can say. Is it clear or you have any doubt? May I know? May I have some reactions if it is clear? What about other people, guys? We have 50 people with us, I think, almost. And I'm seeing two, three, four names. Any disturbances are there in the audio? Am I not clear? Oh, yeah, thumbs ups coming. Uh, is it for the voice or is it for the confusion? Okay, no worries. If you found still the voice is disturbing, let me know because we can resolve the issue. Okay, don't worry. But I hope this topic is making sense to you, because this is a very, I can consider a very basic point which many are not aware of. Okay, so it is a very confusion type of things happens when I ask the students about what is the difference between catheter associated UTI. So always they used to answer like the cout is also asymptomatic, and the ASB is also asymptomatic. There is no such difference, right? But it is not like that. Catheter associated asymptomatic bacteria can be also a possibility. If there is a symptom with it, you can say it is a catheter associated UTI. Okay, and catheter associated UTI, it needs antibiotics, but catheter associated asymptomatic bacteremia, that is bacteria, that is not required any antibiotics to start. Differentiation, if you are able to differentiate these two condition, it can solve a huge issue. Okay, so you can write on a right, you can read on a right side which is written: symptoms are the defining factor for the infection diagnosis. Asymptomatic bacteriuria in the catheterized patient should not be treated. I hope now this sentence makes sense after understanding this whole concept. Okay, now I need to understand what are the symptoms of this required. Symptoms are required for defining a CAUTI, that is CAUTI, the catheter associated urinary tract infection. So to diagnose this particular situation, very specific symptoms are required. Okay, very specific symptoms are required. Like, see, acceptable symptoms that includes fever without another, identifiable source. Fever should be there, should be present in the patient, but there is no other reason can be there for the fever. Like, for an example, if the patient is already having dengue, okay, a patient is already admitted in the hospital on a in a case of dengue, diagnosed with the dengue, and also having a catheter, for an example, and developing UTI further. So fever is there because of some other reason. You cannot consider that for this particular, CAUTI until and unless it is proven. Okay, so fever is important, but without another identifiable source. Second symptom can be this suprapubic pain or a flank pain, which is obviously common in the UTI, and dysuria after the catheter removal. I hope now you have meaning with dysuria. I already elaborated the meaning in the previous slides. So these are the symptoms that can be, this can be there to confirm the catheter associated urinary tract infection. So let me now clearly state what does not count here. Okay, what does not count? Cloudy urine, bad smell of urine, sediments, sediments in the catheter bag. Sometimes sediments are, coming in the catheter bag, and you are assuming that patient might be suffering from UTI. So catheter associated UTI. But these are not count as the symptoms which are required to, make the diagnosis CAUTI. These are expected finding, guys. Okay, cloudy urine, bad smell, sediments, these are expected findings in the catheterized patient and have no correlation with infection. Please understand. Treating based on the urine appearances is a classic type of stewardship mistake, guys. Okay, we cannot do that. So, this is very important to understand what are the symptoms required and what are not required. Okay, so, what are the urine culture pitfalls? Let's understand in the catheterized patients what are urine culture pitfalls we are having. So, urine culture in the catheterized patients are extremely misleading, guys. If it is interpreted alone, I can say. If you are only interpreting the this urine culture in the catheterized patient, it is always misleading. Okay, why? Because it is always high colony counts. These are very common. High colony counts you will be having in the catheterized patient's urine culture. Also, you will be having, polymicrobial growth, I can say. Polymicrobial growth is also common. And biofilm. I already told you what is biofilm. Biofilm organize further the continuously, shed into the urine. So these are very common and misleads. Okay. So high colony counts and polymicrobial growth, these are common finding in the catheterized patients, making culture alone unreliable for the diagnosis. We cannot focus on only the urine culture report whenever we are seeing the catheter, having patient having catheter so insertion. So report, always show you this urine culture report will always show you greater than or equal to, I can say, 10 raised to 5 coronary forming unit per ml, the ratio. Okay, and it will also show multiple organisms also present, but it does not automatically mean infection. Okay, and this is why urine culture should never be interpreted without clinical context. And that is what the stewardship principle is. You cannot rely on the urine culture alone while treating the patient having catheterization. Okay. So, especially in the catheterized patients. So, that is you need to be aware of. These are the pitfalls you need to take care of. Now, let me discuss about this asymptomatic bacteriuria. The definition we will discuss first, and ASB, how to treat ASB, let's discuss. So we discuss about recurrent UTI, guys, and we discuss about this catheter associated urinary tract infection. We found out the difference between catheter associated UTI and catheter associated ASB. So let's discuss now ASB, how you can define it. So let's clearly define this particular situation called ASB. ASB means bacteria is present in the urine. Bacteria is present in the urine because it is a bacteriuria. Okay, so bacteria is present in the urine. See, sometimes definition, falls in the itself, it is, in the heading, in the name itself. So it is asymptomatic bacteriuria. That means bacteria is present in the urine, but no urinary symptoms will be there. Symptoms will be not present, asymptomatic, and no systematic sign of infection will be there. Okay, so we can consider, guys, ASB is not a disease. Can I say that? Is it correct to say asymptomatic bacteriuria is not a disease? Can I say that? Yes or no? Okay, I am receiving your answers. Of course, of course. So I can say on a first extent that ASB is not a disease because no need to treat it, right? Bacteria is present in the urine, but it is not the reason behind the actual cause. And there is no urinary symptoms and no systemic sign of infection. So we can consider at a first extent ASB is not a disease. It is a colonization state, guys. This ASB is a colonization state. So in elderly patients, especially those in the nursing homes, this ASB situation is extremely common, very common. Asymptomatic bacteria. Sometimes it is present in more than, I can say, 40-50% of the patients, guys. Okay, this ASB. So treating colonization does not improve any outcomes, right? So you need to understand definition and prevalence of ASB. Prevalence I already told you, 40-50% of patients having this ASB situation. This is defined as the presence of bacteria in urine without any clinical symptoms. This condition is very common among the elderly population. Okay, so who should not be treated for ASB, guys? This is very important slide. Okay, as I earlier told you, today we are not going to deep dive into pharmacology, therapeutics of UTI or the pathophysiology. We will dive deep into clinical judgment. So we need to understand what we need to identify, what not to identify, who should treat, who should not be treated, right? So who should not be treated for ASB? This slide directly challenge your common clinical practice. Patients who should not be treated for asymptomatic bacteriuria, that includes your elderly patients. Okay, your elderly patients, patients with diabetes mellitus, patients with indwelling urinary catheters, these are the population not be treated for the ASB. Even if their urine culture is positive, even if the organism is resistant, even if the colony count is high, you should not treat with antibiotics. Antibiotic provides zero, literal zero benefit here, and it is causing real harm. Okay, but unfortunately, guys, this practice is not being done in the hospital just because of the risk of treatment failure and just because the risk of worsening the situation. Okay, so whenever there is, the elderly patient case, patient with diabetes and having this urinary catheter and developing bacterial growth, for as a prophylaxis purpose, they added, they have practiced to add certain cephalosporin and fluoroquinolones in the prescription. without any justifiable reason. That is the reason I have kept this module in the clinical syndromic stewardship, so you can have idea that yes, ideally this should not be like this. Okay, and if in certain cases you can advise, so please advise to avoid antibiotic in this situation. It is making no sense. Okay, we have evidences as well for this, so you can show to your team and you can discuss further. There is no need, and we are only contributing to the resistance by giving them unnecessary antibiotics. We are we are making burden, we are working towards the non adherence and a lot. So please understand, antibiotic provides very zero benefit here, and it is causing a real harm if you are treating elderly patients, patients with diabetes, or patient with indwelling urinary catheters. And ASB is the situation. I hope you will remember this slide forever. Okay, this is very important. And who should be treated on a next hand? So if there is ASB, who should be treated for ASB? So I told you one sentence, right? ASB is not a disease, but still I have introduced one slide to you. Who should be treated? So there are only two very clear evidence-based expectations you can have. Okay. So sorry, exceptions you can have. So these two things you need to identify where ASB should be treated. Okay. So whenever patient is pregnant woman, okay, patient is pregnant woman, asymptomatic bacteriuria is there, like if the bacterial growth is being seen but it is not causing the actual symptoms, but the pregnant situation, like woman pregnancy, okay, if the woman is there and it is in she is in a pregnancy stage, of course this is the very first situation you should treat. ASB situation, why? Because untreated bacteriuria further increase the risk of polynephritis further, or preterm labor or low birth weight and all. Just to avoid this situation, we will treat ASB in pregnant women. Second condition where you will be focusing toward treating ASB is the patients undergoing urological procedures. Okay, patients undergoing any type of urological procedures involving any mucosal bleeding. In those scenario you need to treat ASB, because bacteremia further can occur during the procedure as well. So these two are the basic scenarios where you need to treat ASB. I hope you will remember this slide also forever. These two slides are extremely important. Who should not be treated for ASB? Who should be treated for ASB? So, treatment for asymptomatic bacteriuria is exclusively recommended for pregnant women and patient prior to urological procedures. Outside of these two scenarios, guys, ASB should not be treated. No exceptions. Okay, so remember this slide. We have some guideline evidences with us, so this recommendation is not based on the opinion, guys. ये जो दो slide है, these two slides are not based on the opinions. Okay, it is based on the strong evidence. Okay, multiple randomized control trials have been shown that treating ASB does not reduce mortality, guys. It is does not preventing any symptomatic UTI, and it does not improve outcomes. Okay, so many multiple randomized control trial we have published result with us that is showing treating ASB does not means reducing mortality or it is preventing any type of UTI. It is not does not improve any type of outcome. What it does increase is only the resistance. Okay, so if you are treating ASB unnecessarily, you are contributing to resistance. It will increase adverse drug reaction, and of course it includes some increase some clostridioides difficile infection. So from an evidence based medicine perspective, treating ASB is a very poor clinical practice. Okay, you should not do it, and this is evidence based. Okay, so you need to understand this. Now I have one of the case to discuss with you. Let's apply everything we have learned to a real clinical scenario. Now we have here the 78-year-old male patient. Focus on the age, guys. We have 78-year-old. I think some alignment issue is happened with this, but I hope you will be able to understand the whole case. I have written in a bullet point, but something is okay, fine, no worries. So what happens? 78-year-old male that is presents with acute confusion, okay, confused male that is there. Urine culture shows the growth of E. coli. Okay, so here you can see the male presents with the positive urine culture of E. coli. E. coli was also mentioned, but it is somehow deleted. Okay, no worries. Something is bad with this slide. I don't know. Okay, so 78-year-old male present with the acute confusion. Urine culture shows the growth of E. coli. Okay, understand. There is no fever, no dysuria, no flank pain. No fever, no dysuria, no flank pain. Now, this is one of the most common triggers for unnecessary antibiotics in the hospital, guys. Why? Because of age, because of the patient is confused in stage, and because it is present with a positive urine culture. No one is interested to check whether the symptoms are actually present or no. Okay, whether it is a fever present, whether it is a dysuria present, whether it is a flank pain present, urgency, frequency, no one is interested. Only based on the blood culture report, they directly give the medicine. Now give me your suggestion, guys. How should we proceed here? The key question is, does this patient truly have the UTI? Does this patient have truly a UTI? Exactly. And does this patient need any antibiotics? No, correct. No, there is no need of it, and there is nothing is there to justify that there is a it is a UTI case. Of course, it can be some other reason. Now you have idea how to diagnose, how to differentiate, what are the possibility of the other diagnosis, and how exactly we should proceed. Okay, and that's what exactly the clinical judgment is, guys. Okay, so this is very good example to understand, but unfortunately practically kya ho raha hai, what is practically happening in the world around us is, based on the positive urine culture, they are advised further to take the fluoroquinolones and cephalosporins and the big names. So that's where exactly the issue is. Okay, so we need to work on it. And we have now the clinical reasoning. See, the very first step into is not the antibiotics here, it is a clinical reasoning. So you need to understand, are there any urinary symptoms? So answer is no. Are there any systemic sign of infection? The answer is no. Are there any alternative cause of confusion? Of course, the patient is in elderly situation, confusion can be caused by many reasons, maybe by dehydration or electrolyte imbalance, hypoglycemia maybe, polypharmacy maybe, constipation, sleep deprivation. Many reasons are there behind the confusion. Confusion alone is not a sign. Okay, so jumping to UTI is often diagnostic anchoring, we can say. It is not a good decision. So the first step in management is to assess the clinical symptoms and actively look for alternative cause for the patient's confusion. As I mentioned, whether it is dehydration or electrolyte imbalance or hypoglycemia or the polypharmacy, you will be taking history of the patient and you will get to know that what is the exact reason behind the confusion patient is having. Okay, and why not this is a UTI? So in this patient, of course, bacterial colonization is expected due to age, of course. Positive urine culture reflects the case of asymptomatic bacteriuria. Confusion alone does not equally means to UTI. So if we treat this patient with antibiotic, guys, what will happen next? Confusion again will not improve. Risk of harm, of course, will increase. And resistance, we are contributing on a large scale. So the correct diagnosis is ASB here and not a UTI case. And the correct stewardship decision is not to treat. Okay, not to treat. Okay, so this is very important. Now what are the harms of unnecessary treatment? Just imagine this patient is having cephalosporin or fluoroquinolones. Let's talk about what actually happens when unnecessarily you are treating a patient who does not have a true UTI. Very first, drug toxicity and the side effects. Effect is gone, but you can understand. Drug toxicity and side effects. Elderly patient have that altered pharmacokinetics, right? They have reduced renal clearance, they have altered volume of distribution as well. So even routine antibiotic can cause toxicity in these patients. Secondly, of course, clostridioides difficile infection. So this is a life-threatening complication we can consider, especially in the older adults. Okay, and many cases begins with this unnecessary UTI prescription, guys. Trust me. And it can result to death, coma, and lots of things, right? So, this C. difficile infection that leads to hospitalization. Patient might be thinking, and caregivers might be thinking, it is the reason behind it is its age and some other conditions. But we know that actual reason is the drug, and drug is to save people, not to kill people, right? So, of course, we need to take care of these things. And third is antimicrobial resistance. Every unnecessary antibiotic that, selects resistant organisms, not just in the urine, but in the whole gut flora. So, overtreatment is, it is a it is a harmful. And you need to understand that overtreatment is not always a, protective thing. So, it is causing a real problem, guys, and measurable harm, I can say. So these are the things that can happen if the patient is taking unnecessary antibiotic. And what can be our stewardship decision here? So this slide represents the correct antimicrobial stewardship decision. In this elderly confused patient with asymptomatic bacteriuria, we do not start with antibiotics. We will actively search for another causes of confusion patient is having. We will review their medications they are taking. We will check their hydration status and metabolic parameters, and we will remove some unnecessary catheters. So this is not, doing nothing. This is what the doing right thing means. Okay, so maybe some people will tell you that this is something called doing nothing to the patient having complaints, because you are not advising medication, but this is what actually doing the right thing, right? So this is the correct stewardship decision you can take for this type of scenarios. I took specifically elderly population so that you can connect the dots here. And what is the role of pharmacist is the major important point we cannot ignore. So as a pharmacist and pharmacy professionals and healthcare professionals, I can say this is where your role becomes extremely powerful, guys. You are professionals who can question why a urine culture was sent first on first question. Okay, you can question, and you are the one who can identify the absence of symptoms. What is the reason behind report is showing the plus sign, which is positive blood positive urine culture, but the absence of symptom is there. What is the reason? Whether it is catheter, whether it is something else. Okay, you are the reason who can you are the one who can recommend stopping antibiotics if there is no need, if it is a case of ASB, and if the person's prescription is having this cephalosporin and fluoroquinolones, you are the one who will recommend further stopping antibiotic. Guys, please understand, our goal is not to counter anyone. Okay, our goal is not to show our superpower to someone. Our goal is patient centric. Okay, our goal is to anyway, to increase the adherence and to decrease or reduce the load on a patient. We are here evolving around the patient care. This is what our primary goal is. Okay, so do not forget that. You will always recommend stopping antibiotics with the evidences, whatever you have. You can suggest catheter removal if it is not important, unnecessary, right? And you can educate the healthcare team about stewardship decisions, guys. So pharmacists are not just the dispenser of antibiotic, guys. If you are seeing the prescription, elderly people having positive blood culture, you can counsel them, you can ask them, you can solve the issue, right? And if still their prescription is having these things, you can question them, right? That there is no need. So this is what exactly the pharmacist working abroad are, in a abroad, like in a already developed countries, they are doing this practice. That's the reason behind their healthcare is growing, their their pay scale is high. All the reason behind is this, they are practicing these approaches. Okay, they are in a real healthcare, I can say. While I don't know what is happening with us, but this is the ideal way to proceed, right? So you are the one who will guide further the rational use of the therapy or rational use of the drug. I hope you have now meaning clear with your intention should be also good, and your decision should be also in a rational way. What are common prescribing errors you can identify? So there are two very common prescribing errors you will find in the UTI management, guys. Very first is treating a positive urine culture alone, okay, without symptoms. So I will summarize for you. So next time if you are seeing a prescription having no symptom but positive urine culture alone, and writing antibiotics, just question them, okay, or suggest them, recommend them, these things to avoid further the resistance pattern. Second most common error is continuing antibiotics for unnecessarily long duration, because duration is also making sense. Okay, so both errors come from fear, guys. The main root cause, that is fear of missing infection, fear of treatment failure, fear of reoccurrence. Okay, but fear based medicine leads to what? Resistance, not safety, so we need to intervene in it. Okay, so these are some of the common prescription error. De-escalation is very important. I hope you might be having idea about de-escalation. So we will start with the broad spectrum, narrow it down further, that is de-escalation. Okay, so de-escalation is a core antimicrobial principle. I told you in the basic course and in the microbiology as well. So in UTI, de-escalation means narrowing, okay, narrowing antibiotic spectrum once you will be having culture results with you. Switching from intravenous to oral therapy whenever appropriate, that is also de-escalation. And stopping your antibiotics entirely if diagnosis is incorrect, that is also called as de-escalation. Okay, stopping antibiotic is not a failure, guys. It is a successful stewardship intervention we can consider. So do not have any fear to do it. Okay, de-escalation is a powerful uh, tool in a stewardship. And duration of therapy. So this slide corrects a long-standing myth, I can say, that UTI need a long treatment courses. We have this myth, right? But evidence based durations are mentioned here. Uncomplicated UTI has only 3 to 5 days, while complicated UTI needs 7 to 10 days. More than that, it is not recommended. Okay. And also, I will say catheter associated UTI with a good response, usually 7 days. Okay, not written here, but for your exam, for your understanding, just I am saying. So 14-day course, 14-day courses are rarely justified, I will say, in today's healthcare world, and often it is causing more harm than the benefit. But still, unfortunately, I have seen a prescription of UTI having 14 days long courses, and you also might be seeing. But these are recommended duration of therapy. So please have understanding of this duration of therapy things. I hope it is clear to you. This is diagnostic stewardship, guys. So we need to little bit understand about two more slides will be there. So antimicrobial stewardship starts before antibiotics are prescribed, right? And diagnostic stewardship means what? Diagnostic stewardship means do not order urine cultures without symptoms, first and foremost. Okay, if the symptom is present, then and then you need to do a urine culture report. Avoid any type of routine urinary avoid any type of routine urine testing in elderly or catheterized patient, and otherwise you will have it. Okay, you will have it. So because the colonization and contamination is very common, you will have it, you will develop it further. So unnecessary things you need to avoid, and educate your healthcare team about appropriate indications when and where exactly it is needed. So every unnecessary test, guys, that creates pressure. It is creating pressure to prescribe unnecessary antibiotics further. That is what we need to take care of. So that is what diagnostic stewardship. I think in our upcoming modules we have a big module to discuss on diagnostic. That's the reason I am not elaborating it right now. Otherwise, I want to discuss a lot of things. We have very big principles of diagnostic stewardship, guys. I will let you know. But for now, just understand that we are avoiding unnecessary things to diagnose. Okay. What is the key message to take home? So, if you remember only one line from this lecture, I will say, remember, we are treating patients and not the laboratory reports. Okay, so we are treating patients and not the laboratory reports. What is the which is the very basic practice hospital staff is doing. So a culture result supports a diagnosis, but it does not always suggesting you that it is the one. It is not. It is not creating the one. So you need to understand that we need to treat the patient and not the reports. That is the only message I will say for the UTI. What is the clinical pearl here? So let me leave you with very some I can say some simple, very simple but powerful clinical pearls, that Cloudy urine is not UTI. You need to remember. Okay. Then bad smell, of course, it is not UTI. Positive culture without symptom is not UTI. And confusion is not UTI. Okay. Repeating this pearls in daily practice that can, of course, prevent some, big errors and big antibiotic misuse. So those things you need to have in your mind. Knowing when not to treat, this is very important. So I already told you in which scenarios you don't want to treat, okay, and you will not proceed further. So I want to end with this thought only, that antimicrobial stewardship is not about denying the patient's treatment. We are not towards that, but it is about protecting, okay, it is about protecting patients from unnecessary harm. So the most skilled clinicians are not those who prescribe the strongest antibiotics, guys. But I can consider that the strongest healthcare professionals are those who know, yeah, who know that when to, antibiotics are actually needed and when not needed. Okay, so that is all for the session today. I hope it is fruitful for you and making sense. UTI is the big thing to understand. So before we close the session today, guys, I want you to pause for a moment and reflect on what we actually discussed. Okay. I hope now in the summary, I already told you that UTI taught us something very important. Presence of bacteria does not always means infection, right? So antibiotics are very powerful tools for us, but not a reflex response, not always needed. So today you learn that most dangerous prescriptions are often the unnecessary ones, right? And we need to identify it. So I hope now it is making sense to you. And most importantly, you learn today when not to treat, right? So in the next module, you will learn when delayed or inadequate treatment can be dangerous, which will be very fun to understand on our next Thursday. And I will also tell you how to strike the right balance as a responsible healthcare professional. So very important scenarios we will discuss for the next module. We will see in the next module the skin, soft tissue, bone, and joint infection collectively. Very fun. Okay, very interesting. So in clinical syndromic stewardship, I try to collect all the major this syndromes and diseases, so that you can practice in your daily ward round and all, and common as well, I think. Okay, any more questions from your side, guys? Just give me a minute. I will be back. Okay, I can see some questions are coming. As we discussed, for fever, in any case, suppose patient is on meropenem or any broad spectrum antibiotic, patient got 2-3 doses of a day before we are auditing. Next day, there will be no fever, 80-90%. So, how to differentiate that patient is having actual fever or no? So, this is excellent question I can consider. See, if you are absolutely right here, if a patient receive 2-3 doses of meropenem or any type of broad spectrum antibiotic, and next day the fever, settles down, in 80-90% of cases fever will reduce, but that does not automatically prove that there was a true bacterial infection. So the real question becomes, how to we differentiate, okay, true infection fever from any type of self-limiting one, or drug fever, viral illness and all. So very first step you can do is understand the fever physiology. Okay, so fever is always mediated by the interleukins and TNF and all. So meropenem does not directly reduce fever. It is only reducing fever in a case of, I can say, it was caused by the bacteria, and that drug is being targeting. So that you need to understand. Second step can be fever response timeline. That is also very important in case of fever. Okay. So fever may start, improving in 24 to 48 hours, and other parameters should also improve with the fever, like heart rate, BP, and all C-reactive protein, procalcitonin, all the things you need to take care of. Third step can be your, audit approach. Like what should you check exactly? I can say, you will check that was there documented fever? Actual the temperature was recorded at the time, or just the patient felt, little warm? Because that is very objectable, okay? And you also check was there any evidences of systemic inflammatory response, like whether the patient has WBC over 11,000, C-reactive protein is very high, procalcitonin is elevated, hypotension, tachycardia. This all you need to check the collectively. And last, was there any document for focusing on the infection? So that is also you need to check. So all the things you need to collectively do. And yes, fever resolution after broad spectrum antibiotic is not the proof of infection, and I can say it is not a proof of antibiotic was needed, and it is not a proof of carbapenem that was appropriate. Okay, it only means the patient is afebrile. So yes, that is what uh, you can check collectively to understand whether that is actually having fever or not. I hope it is clear to you. Correct? So many things are there to check this. Next question I can check. Just a minute. Just a minute. I will type one message to in my group where I need to start at 8 o'clock the another class, so that they can wait for 5 more minutes. Okay. The next question is patient has positive E. coli in the urine, sensitive to fluorouracil, and patient was advised to cephalosporin and fosfomycin, resistant to most of the all fosfomycin such as alternative. Is it rational? Okay, so shortly I can say cefodoxime is not a rational. Okay, if the isolate is resistant to most of the cephalosporin, if your isolate is resistant to most of the cephalosporin, your this cefodoxime is not rational, unless I can say unless the report specifically shown the cefodoxime sensitivity, whatever AST report you will be having. Okay, so you need to check the culture result like E. coli positive, and if E. coli positive is there, it should be sensitive to fosfomycin, amikacin, gentamicin. Okay, so that you need to check. Then you need to check a secondary thing. I can say regimen of it. Okay, standard dose. So that you need to check alternative duration, like alternative day for 3 days the treatment will go long. So that you need to check, and you will combine further cefodoxime with fosfomycin. That is uncomplicated UTI. The monotherapy is sufficient, but combination therapy is rarely required unless and until it is severe or complicated cases. So rational approach, I can say, if it is uncomplicated situation, fosfomycin single, 3 gram dose is very sufficient. 3 gram is the dose, I guess. Yeah, as per my understanding, it is. And for complicated cases, fosfomycin extended dosing, that is beneficial in this scenario. So fosfomycin will be your rational choice if it is sensitive, and cefodoxime it is irrational. Okay, if it is resistant, that is what I can say. It is completely depend on the scenarios what you are having. So yeah, shortly I can say that. I hope it is making sense to you, because the AST report tells us a lot of things, guys. Okay. Next, moxifloxacin not used in the UTI. Good doubt. This is very common actually, and very important ecology decision, I can say. So moxifloxacin, does not I can say achieve adequate concentration of the drug in the urine, so it is ineffective for the UTI, guys. Even if the lab report shows the sensitive, moxifloxacin is not being in that use. Okay, because it is not achieving the specific concentration to kill. You say treatment is not based on, I say treatment is not based on only laboratory parameters. We need to correlate it with the clinical context. Okay, we cannot rely on a single thing. That's what I mean. Okay. Okay, so if no question is there, guys, we can wind up. I have another lecture at 8 o'clock. So, yeah, see you guys on the next Thursday. Till then, if you are seeing this recording later, also, if you find any difficulties, question, doubts, feel free to drop message in a WhatsApp. I will be there. Okay, I'm just a message away. Okay, thank you so much, guys, for joining today. See you all next Thursday. Thank you.